Let's move to the third section of our lecture, testicular cancer. And in this section, we will discuss about the stage 1 little in detail, how we manage and how we can stage this. Stage 1 of non-seminoma, then stage 2 of non-seminoma cancer, and then both again stage 1 and 2 of the seminomas. Stage 1 non-seminoma. No evidence of disease. It's the stage 1. The stage 1, we already noticed that this tumor in this stage is limited to the testes. So there is no evidence of disease in stage 1 non-seminoma. Alpha fetoprotein and HCG level normal or declining to normal. So it's more or less normal. So it's not that significant at this stage, stage 1 of non-seminoma. Then 20 to 50% retroperitoneal lymph node metastases occur in stage 1 because stage non-seminomas, they spread to lymph nodes, metastasize fast, and they are most frequent, remember. So 20 to 50% in stage 1, they metastasize to lymph nodes. Nerve-sparing retroperitoneal lymph node dissection, nerve-sparing. So nerve should be saved or protected, and then we should do retroperitoneal lymph node dissection because 20 to 50% cases, they already spread to retroperitoneal lymph nodes. Adjuvant chemotherapy in stage 1 non-seminomas. 1 to 2 cycles of it's called BEP chemotherapy, which is bleomycin, etoposide. E is for etoposide, bleomycin, and cisplatin. So these are the chemotherapeutic drugs that are used as adjuvant chemotherapy after the retroperitoneal, nerve-sparing retroperitoneal lymph node dissection. Cured with orchidectomy alone, or we should do the surveillance. Very, very close observation, close follow-up should be done, and then that's also. So these are different treatment options. We can do the nodal dissection, then we can do the adjuvant chemotherapy, and then the can be almost treated with the orchidectomy alone, in which the testes are removed because it's stage 1 non-seminoma and limited to the testes. Removal of the testes can cure the patient, and then close observation and surveillance is done. Followed by periodic chest radiograph and physical examination. That's important to look for the extent of the disease. CT scan of the abdomen and tumor marker determination. So all these are important during the surveillance period. We should look for the tumor very closely, perform the tumor marker study, perform the CT scan of the abdomen, and periodic chest radiography and physical examination should be done. Stage 1 again, non-seminoma, lymphatic or vascular invasion if occurs. First we talked about it's not a significant disease or it's limited to lymph nodes only, 20 to 50%. Now if there is spread of the tumor, lymphatic or vascular invasion, we should do the retroperitoneal lymph node dissection and adjuvant chemotherapy. Clinical stage 1B disease, surveillance, adjuvant chemotherapy, lymph node dissection. More than 95% of the patient, they are cured by this treatment. So again, stage 1 also, depending on the extent of the disease, cure is very good. More than 95% patients, they are cured. Retroperitoneal lymph node dissection, removal of retroperitoneal nodes. Remove lymph nodes during primary site, draining primary site, so it removes the lymph nodes, draining primary site. Removal of node groups adjacent to primary site. Remove all nodes bearing tissue down to great vessel bifurcation. Retrograde ejaculation with resultant infertility and nerve sparing preserve the anterograde ejaculation. So the lymph node, retroperitoneal lymph node metastasis, what different lymph nodes are dissected? Retroperitoneal, then nodes draining primary site, adjacent to the primary site. Here the primary site is the testis. So near the testes, near the close to the testes, and that lymph nodes that are draining the testes. The removal of nodes bearing down to tissue at the level of great vessel bifurcation, where the great vessel divides into two. Sometimes with this we have retrograde ejaculation with the infertility occurs, and there is in cases where the nerve sparing or where the nerve is spared and lymph nodes are dissected, in those cases we preserve the anterograde ejaculation. Ejaculation can be saved. Now stage 2, non-seminoma. So stage 1 we said mainly the retroperitoneal lymph node dissection along with adjuvant chemotherapy. Sometimes orchidectomy is all that we need, but in retroperitoneal lymph node dissection we go for the nodes that drain the primary site, close to the primary site. They can cause the retrograde ejaculation and infertility. If nerve sparing dissection is done, we can preserve the anterograde ejaculation. Now, stage 2 non-seminomas, ipsilateral retroperitoneal adenopathy. Less than 2 centimeter in largest diameter, normal level of alpha fetoprotein and HCG, modified bilateral nerve sparing retroperitoneal dissection is done, and chemotherapy. So mainly the same treatment options as for stage 1. Surveillance in this case, resected low volume metastasis, tumor load less than 2 centimeter diameter and less than 6 nodes involved. 2 cycles of, so if the tumors is limited to these, within these characteristics, we should do the close observation. Less than 6 nodes involved, tumor nodes less than 2 centimeter, that's the surveillance. 2 cycles of adjuvant chemotherapy in case of relapse, high volume metastasis, more than 6 nodes involved, extranodal tumor extension, and cure, which is more than 90% of the patients are cured with 2 cycles of chemotherapy. Again, increased alpha fetoprotein or HCG levels, metastatic disease outside retroperitoneum, we should give full dose chemotherapy. Primary management with chemotherapy if tumor larger than 2 centimeter or there is bilateral retroperitoneal nodes are affected. Now stage 1 and stage 2 seminomas and how we treat and manage them. Stage 1 and 2 inguinal orchiectomy. Testes are removed through the inguinal canal. Immediate retroperitoneal radiation therapy. Surveillance, low-term follow-up is essential. Long-term follow-up is essential. We should follow up the patient for a long time to look for the recurrence of the tumor. Dose of carboplatin, stage 2A and small 2B retroperitoneal radiation therapy. So again, orchiectomy, retroperitoneal radiation, surveillance, long-term follow-up, dose of carboplatin. All these are different treatment options for stage 1 and stage 2 seminomas. Initial chemotherapy for all stage 2C and some stage 2B patients. Alternative to radiation for stage 2A and small stage 2B. Low recurrence rate and 3-time increase in secondary malignancy and cardiovascular diseases. So, initial chemotherapy for all stage 2C and stage 2B patients. These are, there is low recurrence rate with these after the chemotherapy, but they are associated with some effects like secondary malignancies and cardiovascular diseases. So that was all about the staging and treatment of non-seminoma 1 and 2 and seminoma 1 and 2 tumors. Thank you for watching sqadia.com.